Yeah, hi, this is Khalid Shebani. We will be demonstrating the salient technical aspects of the vertical sleeve gastrectomy. Patient is a 57 years old female. BMI is 63 kg per meter square. We will be using the black tri-stable technology loads. We will use a 34 French bougie for the sleeve sizing. This video is for educational and technical purposes only. We do not endorse any of the products seen or mentioned in this video. We start by exposing the stomach. We retract the left lobe of the liver anteriorly by attaching a grasper to the diaphragm. Now we're going to identify the pylorus as our anatomical landmark. We will use a marking ink to mark the prepyloric antrum about 4 centimeters proximal to the pylorus. That will be the starting point of the stomach mobilization as well as the stomach transection. Now we are dividing the greater omentum and the gastrocolic ligament to get access to the lesser sac or the space behind the stomach. We are using here the harmonic scalpel, and we will continue the mobilization going upwards or cephalads. Now we are seeing a view of the lesser sac or the space behind the stomach. And as you can see here, the mobilization is virtually bloodless. The harmonic scalpel works very well. It coagulates the blood vessels as well as divide them. And we are going now to the top of the stomach. Now we're gonna encounter the short gastric vessels that come directly from the spleen. We have to be very careful here because if you injure the spleen, that can lead to excessive bleeding, may require an open surgery or the exploratory laparotomy, or even splenectomy or removal of the spleen. And mobilization is coming nicely. We are gonna mobilize the stomach to the level of the lift cruise of the diaphragm that's indicated with the arrow. And this is the final vessel that we have to divide. Now we're going to finish mobilizing the stomach distally by finishing the gastrocolic ligament. And I find it almost easier to start proximally and go back to this step, since the access to the lesser sac is usually easier proximally. Now this is again, now the mobilization is nice. Now we're going to pass the sizing rubber rod. It's called the bougie, and we are using 34 French size bougie. Now we're going to transect the stomach. We stay away from these incisura angularis. As you can see here, we are using black tri-stable technology loads, and it's reinforced with neonet surgicel as a buttressing material. This has worked for us much better than the peri strips, the seam guard staple line reinforcement, or the biosyn coated duet staples. Now we are finishing transecting the stomach, and we're going to advance now the stapler. just next to the spleen. You have again to be careful with the spleen here. And this is the final firing. The transection is complete. We take the bougie out, pass an nasogastric tube, and insufflate air. With saline irrigation, we inspect the staple line for any air bubbles, and we don't see any, and this concludes my VSG technique.